In this section, we're going to be discussing PAD and PVD, so peripheral artery disease and peripheral vascular disease. So let's get started. Let's review arteries versus veins. So arteries and veins are the two main types of blood vessels in which the cardiovascular system is made of, and they transport blood to every single cell of the body. Arteries carry oxygen blood away from the heart to the rest of the body. Arteries with an A, away. So that oxygenated blood is going away from the heart to the rest of the body. And the veins carry the deoxygenated blood back to the heart, back to the lungs, so it can get reoxygenated. Arteries are specially adapted for the transport of highly pressurized blood, whereas veins have features that allow them to move blood against the direction of gravity. So arteries carry blood away from the heart. Veins bring the blood back to the heart to get reoxygenated. Now, of course, in medicine, there always has to be an exception to the rule. But if you just remember that arteries always carry blood away from the heart and veins carry blood back to the heart, it's easy to remember. Except we have one exception, and this is the pulmonary artery, which carries deoxygenated blood from the heart to the lungs. And the pulmonary vein carries oxygenated blood from the lungs to the heart. So that is the only exception. If we're talking about arteries, we're talking about oxygenated blood going to the rest of the body. Veins, we're talking about deoxygenated blood coming back so it can get reoxygenated, except for the pulmonary artery, which puts that blood back into the heart and lungs to get oxygenated, and then that oxygenated blood comes out of the pulmonary vein. It's the only exception. So here is a nice visual for you to see the blood vessels, the arteries and the veins. The arteries are red and the veins are blue. Now, when we talk about venous disease, remember the veins carry the deoxygenated blood back to the heart. So if we have a venous disease, the blood isn't getting back to the heart very effectively. It's hanging out in the periphery. It's not getting any refreshed oxygenated blood because it's hanging out in the periphery. It's having a hard time getting back to the heart and back to the lungs. When we talk about peripheral vascular disease, we're talking about that there's a problem of blood flow in the periphery. It's not getting back to the heart and lungs to get reoxygenated. So a lot of our signs and symptoms we're going to see in the lower extremities. Okay, remember veins take the blood back to the heart and lungs to get reoxygenated. But with peripheral vascular disease, that blood is not getting reoxygenated. It's hanging out in the periphery. And when our muscles don't have fresh oxygen, what happens? They start cramping, they start hurting. So you're going to see a lot of signs and symptoms in the lower extremities with peripheral vascular disease. So again, our veins, they have a job to carry the deoxygenated blood from the extremities to the heart and lungs to get reoxygenated. It takes blood toward the heart, and it only does this with healthy veins and healthy valves, so the blood can actually move up, move around in the body. If our veins aren't that healthy, then blood is going to pool. It's not going to move as easily as it should. So you're going to have venous congestion in the extremities. So like I said before, if your muscles aren't getting fresh oxygen, getting replenished with that really rich nutrient blood, you're going to have heavy throbbing pain in your legs. You're going to have stagnant blood hanging out, so there's waste in there. So your skin might be discolored, like a brownish skin, and you're going to have venous stasis ulcers. So what are some risk factors for PVD? So anything that increases venous pressure in the veins to make them overstretch over time. So they become kind of overstretched. They're not as elastic as they should be. Females using birth control pills have a risk for developing PVD. Pregnancy, obesity, sitting or standing for long periods of time, not getting that circulation going, and advanced age. So what causes PVD? The most common cause of PVD is atherosclerosis, and this is a buildup of plaque inside the artery wall. So if we have this buildup of plaque, it's going to reduce the amount of blood that can get to the limbs because it has to work through all this plaque that's built up in the artery. So it decreases the oxygen and nutrients available to the tissues. And one thing we worry about is blood clots that may form in the artery walls, further decreasing the inner size of the blood vessel and blocking off major arteries. So over here on the right, there's a visualization. You can see if the blood's trying to get through a vessel and it's congested with this plaque, it's not going to get through as efficiently or as effectively. And then of course, if there's a blood clot forming, then no blood is going to get down. And that's when you're going to have the signs and symptoms of your muscles and not getting the oxygen that it needs. So again, here's another visual of PVD. So the veins cannot help get the blood back to the heart. The valves have become overstretched over time or damaged with the plaque, or there's a clot in there, so that blood just can't make it back to the heart. So what's going to happen? The blood is going to pool, it's going to be stagnant, it's going to be hanging around in one area for too long. And this is going to cause swelling of the extremities, edema. You might get varicose veins. They're like rope-like veins with overstretched valves. And you have a possibility of getting a deep vein thrombosis, which is a clot in the veins. And it's very dangerous because if that breaks off and goes to the lungs, you can have a pulmonary emboli. So if you're assessing a patient and a patient has a history of peripheral vascular disease or peripheral venous disease, you need to be assessing for DVTs, those deep vein thromboses. And signs and symptoms, it's usually in the calf. The area is going to be warm. It might be hard. It's going to be red. It's going to be painful. And we can use an ultrasound to detect that. We can have superficial venous thrombosis. So these are clots developed in the hands or the feet. And then chronic venous insufficiency. So our veins are just too overstretched, too overworked. They're not expanding and contracting like they should to be able to move that blood upward toward the heart and the lungs. So here's a mnemonic to help you with venous symptoms. We're going to call them vessels, V-E-S-S-E-L. So V, various positions. So patients like to elevate legs because this helps with the pain and decreases swelling, and it gets the blood back to the heart. So we're lifting the legs up, we're helping the veins move that blood back to the heart. E is for explanation of pain. Now their muscles aren't getting any oxygen or nutrients, so the pain is going to be heavy, dull, throbbing, aching. It's going to be worse when they're standing and sitting with their legs down. So this is why elevating the legs decreases that pain and swelling. The skin of the lower extremities. So remember, there are no issues with blood flow getting there. The issue is with the blood flow coming back to the heart. So the skin is going to be warm to touch, but it's going to be thick and tough and maybe some brownish color to the skin because we have some pooling going on underneath the skin. The next S is for strength of the pulse. You're going to have present and normal pulses because the blood can get down to the extremities. Has a hard time getting back up. So we're going to see edema. It's very common and it's usually worse at the end of the day, especially people sitting or standing for long periods of time. The L is for lesions, so ulcers. The locations are usually on the medial part of the lower legs, the medial ankle region. The ulcers can be swollen with drainage, granulation present. Blood is getting there, but the edges are going to be irregular and the depth is going to be shallow. And here's a picture on the left for you to see. So what's our job as nurses in our interventions with PVDs? We want to increase the blood return to the heart. We want to make sure that our patient's skin is cared for. We want to prevent infections, especially if they have those ulcers going on. We need to be assessing for signs and symptoms of clots. We need to monitor for clots. Remember, they're going to be hard, red, painful areas, usually in the calf. We're going to be prescribing or giving anticoagulant medications to keep the blood from clotting. And patients might actually need a filter placed in their inferior vena cava. So this kind of catches any clots that might be potentially trying to get into the lungs to cause a pulmonary emboli. So again, these veins need help with the blood draining back to the heart. So we're going to elevate the lower extremities above the heart so we can drain it back to the heart. We can apply compression stockings in the morning to keep compression to help the veins kind of keep moving that blood up. We want to keep these stockings clean and dry. And of course, we want to provide wound care for venous stasis ulcers. And we can use an Una boot with zinc oxide with compression, of course, if that's ordered with the provider's prescription. But our job is to keep the extremities as healthy as possible. Peripheral vascular disease is not going to happen overnight. It's not going to occur overnight. It's a slow and progressive circulation disorder. The vessels are narrowed, they're blocking, they might spasm, and the blood can't really get moved back up to the heart. So peripheral vascular disease may affect any blood vessel outside of the heart, including arteries, veins, and lymphatic vessels. Organs supplied by these vessels, such as the brain and legs, may not be getting enough blood flow for proper function, but you're really going to notice mainly in the legs and the feet. So here's a picture on the left of a patient suffering from peripheral vascular disease. So what are some symptoms your patients are going to complain of? Well, the most common first symptom is painful leg cramping that occurs with exercise and is relieved by rest. And this is called intermittent claudication. So remember, the blood can't get to the muscles down there. So when you're using the muscles, the muscles are saying, "Where's my oxygen? I don't have any rich oxygenated blood." So their legs are going to be cramping. During rest, the muscles in the legs need less blood flow, so the pain is going to disappear. And it can occur in one or both legs, depending on the location of the clogged or narrowed artery. There are a few ways that PVD can be diagnosed. One is with an angiogram, so they take an x-ray of the arteries and veins to see any blockages or narrowing. And this procedure involves inserting a thin, flexible tube into the artery in the leg, and then they inject a contrast dye, and the contrast dye makes the arteries and veins visible on the x-ray to see if there's any blockage. They can do an ankle brachial index or an ABI, and it's just a comparison of the blood pressure in the ankle with the blood pressure in the arm using a regular blood pressure cuff and a Doppler ultrasound machine. And the systolic blood pressure of the ankle is divided by the systolic blood pressure of the arm to see how much of a difference there is. Some other ways to diagnose PVD, you can use a Doppler ultrasound. So this uses high frequency sound waves in a computer to generate images of the blood vessels and tissues and organs, and it's used to measure the absence of flow of blood. So faintness or absence of sound may mean blood flow is blocked. And then we can use a magnetic resonance angiography, or MRA. And this is a non-invasive test. It uses a combination of a large magnet, radio frequencies, and a computer to produce detailed images of organs and structures in the body. And the provider injects a special dye during the procedure so that the blood vessels are more visualized. They're more visible. Sometimes patients can do a treadmill exercise test where the patient will walk on a treadmill and the provider can monitor blood circulation during exercise. Or we can do a PPG. This is an exam It's comparable to the ankle brachial index, except that it uses a very tiny blood pressure cuff around the toe and a PPG sensor, which is just an infrared light to evaluate blood flow near the surface of the skin, and it records waveforms and blood pressure measurements. So this is compared to the measurements in the systolic blood pressure in the arm. So there are many ways to diagnose PVD. Again, some more ways to diagnose PVD. You can do a pulse volume recording or a PVR waveform analysis. And this technique is used to calculate blood volume changes in the legs using a recording device that displays the results as a waveform. Or you can do a reactive hyperemia test, and it's similar to an ABI or a treadmill test, but it's used for people who can't walk on a treadmill. So the patient is lying on his back, and comparative blood pressure measurements on the thighs and ankles are taken to determine any decrease between the sites. So what medications do we use for PVD? Well, of course, the medications we use, we want to improve blood flow, such as antiplatelet agents, such as blood thinners, and medicines that relax the blocked blood vessel walls. So we want those to vasodilate so that more blood can get through. And of course, we don't want our patients to develop a clot, so we're going to give them antiplatelet agents or blood thinners. So how do we differentiate PVD versus PAD? They're going to be different assessment findings. Remember Dr. Epp. So arterial versus venous. So the skin of the lower extremities, the color and temperature are going to be different. With the venous, remember the blood can get down to the extremities. So the extremities are going to be warm to touch, but then the blood is going to be pooling there. So their skin is going to be like a brownish color and thick and tough skin. Whereas the arterial disease, the blood really can't get down to the periphery. So our skin is going to be cool to touch. It's going to be thin and dry and scaly skin. We're going to see hairlessness. We're going to see thick toenails. Remember Dr. Epp. So dangle legs, when we dangle our legs with PAD, we're going to see rubor. But when we elevate the legs with PAD, they're going to become pale. So here's some more visuals for you to see. So with PVD, remember we like to elevate our legs because that blood flow needs help going back to the heart. With PAD, the blood flow needs help going down to the extremities. So we're going to have our legs hanging down to help gravity help bring that blood down. So peripheral artery disease. So the blood can't get to the periphery. Remember with PVD, the blood can go down fine, but it can't get back up. With peripheral artery disease, the blood is having a hard time getting down to the extremities. It likes to stay up by the heart. So oxygenated blood does not go out and give muscles oxygen to function. People with peripheral artery disease, they're going to show signs and symptoms in their lower extremities. The arteries carry oxygenated blood from the heart to the periphery. The heart pumps out the blood to the rest of the body when it contracts, but if the extremities can't get oxygen, then ischemia is going to occur. So atherosclerosis causes a lot of peripheral artery disease. With PAD or peripheral artery disease, you're going to see a lot of ischemia. Pain and ulcers can occur and can lead to necrosis, and this actually might lead to amputation because the blood is not getting down there to feed all those muscles. So risk factors for PAD. So we're going to have vasoconstriction problems. Smoking can cause this because it does cause vasoconstriction. We can have uncontrollable hypertension because it damages the arteries due to the continuous high pressure, high cholesterol because that's going to increase the plaque. Atherosclerosis with a high fat count, again, this is going to contribute to the plaque. and then diabetes. So again, with PAD, the blood is not getting to the extremities because our arteries are too narrow. There's no blood getting down to the periphery. So ischemia is going to occur and tissue integrity is going to be compromised. Atherosclerosis, those are their fatty plaques that collect in the arteries, are going to create blockages. And these fatty plaques can actually rupture, and then a clot can be formed, and then blood flow is even more compromised, more impeded. So when you're thinking about some nursing diagnoses for peripheral artery disease, think about what's going on. We're not getting any blood flow down to the periphery, out to the extremity. So we're going to have ineffective tissue perfusion. We're going to have impaired skin integrity because our extremities and tissues out toward the periphery are not getting the nutrients filled with all that oxygenated blood. We talked about the acute pain because, again, the muscles are being starved of oxygen. The patients probably don't want to walk around. They're going to have activity intolerance because of that pain. And they're probably seeing you because they have ineffective therapeutic management of what's going on in their body. And so that's a great nursing diagnosis as well. So when you're thinking about nursing diagnoses, think about what is happening inside the body, and then you can easily come up with your nursing diagnoses and the rest of your care plan. Okay, we can use the same mnemonic for peripheral artery disease. So various positions help. So it helps to alleviate leg pain when they dangle their legs because the ischemia in the legs and the blood isn't getting to the extremities. So when they dangle their legs, it helps the blood get down to their extremities. When they elevate it, it makes the pain even worse because it limits the blood supply even more. The explanation of pain, the pain is going to be sharp. It's going to be worse at night. It's called rest pain with the legs at night. They're going to have pain in the leg, and they might actually throw their leg off the bed to help the blood get down further down the legs. This is intermittent claudication, severe pain with legs or thighs or buttocks due to increased demand for oxygen because that blood is not reaching that periphery. So how is the skin going to look with PAD? The skin of the lower leg extremity, the issue is with blood flow going there. So the blood flow isn't getting there. So the skin is going to be cool to the touch and there won't be any nutrients. So no hair on the legs. It's going to be very scaly. You're going to have thick toenails. When they dangle, the legs will be red. And when they elevate their legs, the legs are going to be pale. So you're going to have a hard time finding a pulse because the blood isn't getting down to the extremities. Edema is not common. And these ulcers will be at the end of the toes or the top of the feet, like the lateral ankle malleolus on the outside. There's going to be very little drainage, very little tissue granulation. It's going to be pale, necrotic, deep. It's going to have like a punched out look. And the margins and edges are going to be round, and the skin is going to be very thin and scaly because you're not getting any nutrients down there. So what are we going to do to help patients with PAD? So we need to be worried about circulation and pain control, and of course skin integrity. So we need to be checking pulses frequently. We need to compare right to left. We're going to be using the Doppler. We're going to be assessing the skin color. Is it white, blue, or black? We're going to be assessing their sensation. Can the patient feel you when you're touching him? The temperature, is it going to be cold or hot? And then an education to improve circulation. So we're going to say avoid wearing tight clothing because this will impede blood flow even further. Remember, we need to get that blood down to the extremities. It's having a hard time getting down. Some more nursing interventions with peripheral artery disease. We want to avoid cold because we do not need any more vasoconstriction. We're going to teach our patients to stop smoking because that causes vasoconstriction. We're going to teach them how to position themselves properly, so we're not going to cross our legs because, again, that's going to impede blood flow. We're going to take our medication as ordered, such as cholesterol medications and anticoagulants if ordered. We're going to follow a low-fat diet because we do not need any more plaques in those arteries. And we're going to participate in a walking program to decrease that intermittent claudication by increasing oxygen to the extremities. So with our patients with PAD, we need to assess their skin daily to notice if there's any decreased sensation. Sometimes people with PAD don't really have great sensation, so they might have stepped on something, they might not have felt it, and this might be a risk for infection. So we need to assess and manage any pain that they're experiencing. Again, we can do the ankle brachial index measure in the legs compared to the arm. Less pressure in the legs is PAD. And then we can use a percutaneous transluminal angioplasty where a stent is actually placed to open a vessel to allow more blood flow to get to the extremities. So here's just an illustration of the percutaneous transluminal coronary angioplasty where they kind of go in and expand that vessel so that blood can pass through that vessel more easily so that we can get all the rich nutrients and oxygen down to the extremities. Sometimes the arteries are too badly gone, so they might need a peripheral artery bypass where the surgeon actually bypasses the blockage and reroutes the blood flow around the blocked area, or an atherectomy where they just go in there and they rotor-rooter or remove the fatty plaque, again to open that vessel so that blood can flow more freely. So here's a slide with an atherectomy showing you how they kind of go in and rotor-rooter those arteries to get all that plaque out so that blood flow can increase to the periphery of the body. So again, just reviewing PAD versus PVD, I put all of the arterial signs and symptoms in red and the venous signs and symptoms in blue. So you can remember the mnemonic VESSEL, VESSEL. So remember, V is for various positions that alleviate pain. So when we're talking about arterial damage, remember dangling those legs down because the blood can't go down to the periphery is going to help the patient feel better. And then with venous, we need to elevate the legs to alleviate the pain because this decreases the swelling and the blood is not getting back to the heart. E is for explanation of the pain. So those with PAD, they're going to complain of sharp, worsening pain at night, rest pain, and remember when their legs are horizontal in bed, they're going to throw off their legs in the middle of the night and let them dangle because they're trying to get rid of that cramping. And then your venous patients, their pain is going to be a heavy, dull, throbbing, aching pain, and it's going to get worse when they are dangling. S is for skin of the lower extremity. So with our arterial patients, the perfusion is not happening. So it's going to be cool. The skin is going to be tough. The skin is not getting any nutrients. So they're thin and dry and hairless. You're going to see thick toenails and you're going to see color changes with dangling. Ruber, red with dangling, because elevating the legs is going to impede that blood flow. With venous perfusion, or venous patients, the perfusion is fine, but it can't get back to the heart. So the extremities are going to be warm to touch. You're going to have this thick skin. It's going to be tough. They might be swollen and brownish in color. So S is for the strength of the pulse. And remember, with our arterial patients, the circulation is compromised. So we're going to have poor pulses, or the pulses might not even be there. They might be absent. You might have to use a Doppler to actually hear them. The venous patients, remember the problem, it's not the problem with the blood getting there, it's the blood getting out of there. So their pulse is probably going to be normal. And then the E is for edema. With arterial, remember, you're not going to really see too much swelling versus venous. You're going to see a lot of swelling with the venous patients. L in our mnemonic for vessel stands for lesions. So the arterial patients, we're going to see lesions on the toes, on the lateral malleolus. We're not going to see a ton of drainage because remember the blood flow is having a hard time getting there. So if we have any new wounds, the healing probably won't happen that quickly. and they have like a punched out skin appearance. It looks like someone punched out the skin if you look at their lesions. And venous, on the other hand, you're going to see lesions on the medial part of their ankle. It's going to appear swollen. The skin is going to be tight. There's going to be drainage and granulation because blood flow is there. Remember, it can't really get back, but it's there. And usually these lesions have an irregular shape.